Good morning, and I'll just scoot over here so I can see myself better. Good morning. My name is Linda Govan, and I am the Westwick PHN Regional Senior Manager for the Ballarat Goldfields region, and I'm speaking to you this morning from Wadawurrung Country. I'll be your facilitator for this second session in our primary care stream on Sunday. So I'd like to introduce you to this session. It's Nurse Clinics, Business Modelling and Team Engagement with Kim Poyner and Riwka Hagen. So it's a nice segue from our previous session this morning. We want this session to be interactive, so pop your questions in the Q&A and we'll tackle them as we go through the session rather than holding them to the end. And I'd also like to thank Lake Imaging for sponsoring this session, and remember to pop over to the Sponsors Lounge in between the sessions during today. So now I'd like to welcome our speakers, and I'll start with Kim Poyner. Many of you would know Kim. And Kim has an extensive history working with medical centres and primary health networks to train medical professionals in behaviour change theory and chronic disease management. Kim was awarded the 2015 Australian Best Practice Nurse Award in Chronic Disease Management, and she's currently training health professionals across Australia in the healthcare home trial readiness projects and quality improvement strategies. And you may be able to hear my dog in the background there, and I do apologise, but we are all working from home today, so this is just how it goes. And Riwka Hagen is the Director of Medical Business Services, providing consulting, advisory, coaching, training and mentoring services to the health sector Australia-wide. Riwka has a strong interest in quality improvement, business planning and financial management. Riwka is also the founder and administrator of the highly active and influential Facebook group Practice Managers Network, which now has a global membership of 6,000 people, and I'm one of those members, and it's a really valuable resource. And I'd like to hand over to Kim and Riwka now. Thank you.
Oh, thanks so much for that, Linda. It's really delightful to be here on this sunny but cold Melbourne morning to have a chat to you all about, I guess, really focusing on the business modelling component of nurse-led clinics and how that interacts with the importance of really effective team engagement. So Kim and I will kind of bounce off each other as we work through this particular session. So what you'll see on the screen here now is a very colourful mind map that will align very closely with the previous session that hopefully you've just attended as well, on all of the thinking points in terms of developing nurse-led clinics. And one of those areas there, one of the spokes is around business modelling, and I want to assure everyone that we'll make sure that this particular mind map is made available to all the attendees to download as well, so you'll be able to get that through the portal and through Westwick PHN after this session. So not wanting to sort of reinvent the wheel in terms of all of the steps in terms of starting and implementing nurse-led clinics, we really wanted to focus on the importance of the budgeting and getting that business model really strong. What we're hearing a lot of is, that practices sort of really struggle with getting a good grip around what are the finances going to look like when you implement especially a new nurse-led clinic. So these are some of the areas that I want to have a talk to you about. You'll see in this slide too, there is a URL there to the APNA Building Blocks Funding area. And in there you will see there is a deep dive explainer on all of the thinking points that we're just going to run through fairly quickly this morning. So when we're thinking about budget planning for nurse-led clinics, we're really wanting to contemplate what are all the revenue streams that are going to come out of, the nurse-led activity, and then also what are all of the expenditure items, so that you can kind of pre-plan whether your clinic is going to have legs and whether it's got that viability sort of, of its own accord. And so in terms of the income sources, what we're going to be really looking at is ostensibly all of the Medicare MBS item numbers that you may be able to claim in association with this nurse-led clinic. You might also want to factor in some gap fees that may or may not be appropriate for whatever service it is that you're planning on developing. You might also start to think about some gap fees for nurse-only services. So I guess I kind of want to sort of throw out that innovation piece around not being restricted solely to thinking around MBS and what the bulk bill revenue might be looking like. I'd really encourage you to start thinking about the value that your nurses can bring to these bespoke services and how you could monetize that as well. And it's not necessarily a fait accompli to say that if there isn't an MBS item number attached to it, then we can't run the service. So just kind of being a little bit more innovative around that. So the budget modeler, and I'm going to show you a spreadsheet which is part of that budget planning work that you can do, also allows you to incorporate things like your QIPIP funding as part of the modelling for these kinds of services. And you can also consider the workforce incentive payment as it applies to your nurses as part of that budgeting for that overall service. And then finally, you might also have some other revenue streams that are a bit more bespoke, and they might be grant funding through your PHN or through other streams that could be incorporated into that development as well. In terms of the expenditure, and again, I'm just being mindful that we're running through this really rather quickly because there is a lot more information about this available through the learning portal of APNA and you know the actual spreadsheet there too for doing that budget planning. But in terms of the expenditure items, the planner will allow you to factor in the distributions to your GPs. And for most services, when you're thinking about nurse-led services, the majority of the expenses associated with running that service is still going to be the distribution to your GPs. So the modelling will allow you to play around with percentages to start finding the sweet spot of where your service becomes viable, or perhaps where you know, things are kind of looking a little bit shaky and may not sort of support that ongoing viability of the service. Then secondly, we'll be looking at staffing costs and any other costs associated with your service. So you can also incorporate things like, you know, room costs and operational costs of your practice as part of that overall budget planning. So what does all of that look like as far as the budget planner is concerned? Here's a little bit of a screenshot of the current APNA nurse clinic budget tool. And I guess the reason that I'm pretty sort of excited about this is that I was very heavily involved with APNA in actually developing this tool, and it's certainly kept up to date to ensure that the information in there is kind of relevant and appropriate at any time. But it shows you quite clearly here in the blue section all the areas where you are going to be inputting your activities, so your MBS item numbers, your nurse-only item numbers, your QIPIP inclusives, and the like. And then on the second side, on the green side on the right there, is where you're going to have a go at establishing the expenditure associated with this. Now, the really good thing with this spreadsheet is that a lot of the calculations will be done automatically for you. So you've got to get your base numbers right, and then the modelling will come out. Certainly not within the last dollar or the last cent, but it's going to give you a really good sense of how that's going to track for you. So just a slightly closer look at that income calculator, and it shows you that it starts off with suggestions of, you know, care planning and team care arrangements and health assessments and a whole lot of other item numbers where you can factor in both how many services you would be planning for a particular session and how long your nurse and your other staff are going to spend on providing those services. It will then calculate out for you the revenue that's going to be generated out of that. So again, it's just a very quick run through on that item. So come back to the slides and just go back to that URL of the APNA resources, because you're going to find all of those details in there, and definitely a worthwhile activity to undertake. So in terms of that nurse clinic budgeting tool, this is going to help you with the business case development. It's going to really help you sort out what you're going to do and how your service is actually going to run. And it will therefore allow you to do some scenario planning. So by playing with the numbers and playing with the services, you're really doing that sort of what if type of analysis. What if we did more care planning? What if we incorporated health assessments? What if we applied gap fees? All sorts of scenario planning to help you really define the services that you're going to be providing. And like I indicated just before, it's going to help you to understand the impact of the GP distributions on the viability of that clinic as well. So really, I guess what we're wanting to encourage here too, and this is definitely going to seg into Kim's session on team engagement, is that by undertaking this activity, you really already want to be starting to engage your team in actually answering some of those what-if questions. So get your nurses together, get your practice manager together, and certainly your GPs as well, to start having that conversation around what could it look like, what might it look like, what's going to work for our individual circumstance, and what factors are really pertinent to our practice that we have to keep in mind. So in Becquerel there, it's about leveraging your team, and I'm going to flip it across to Kim.
Thanks so much, Riv. This is just core, isn't it? It's core to the things that we do in primary care, and it sounds really easy. We've got the thinking components, we've got the planning, we've got all the ideas, we might have all the enthusiasm, we may have number crunched and gone, this is actually a really great business viability for us moving forward. But the human component is critical, isn't it? So we're going to see which components of our humans can we start to, as Ruth said, leverage up, so that we have everyone enthused, everyone knows what we're doing, and what are we trying to achieve here. And particularly with team-based care, we're striving to improve patient outcomes. There's no doubt about it. We want to do that preventative focus, those upstream issues, so that we're being really accountable to the healthcare dollar. So how do we do that? We optimize what we have, and Riwka showed you and demonstrated in that budget tool that there are many item numbers that can be on that preventative focus, such as health assessments, heart health checks. I know we can talk about those sorts of things for sure for days on end, but there's also chronic disease management. We know if we're really proactive, we can actually keep a lot of people out of hospital. We also want to reduce fragmentation, duplication, and replication, don't we? And we want to move away from this siloed approach to everyone just being really blinkered by what others are doing already. So we're just moving through. What we're striving to do is to have more an interdisciplinary approach, more cyclic discussions with many. There is many teams that's involved in that client, keeping them out of hospital, keeping them living a good life. The quality of life is really important here, isn't it? So the client at the central focus, and all these channels of communication. We know from the McKinsey report, effective communication is an effective hospital avoidance strategy. So that's externally to all these people, but internally is more crucial. So moving on, Rick. So how do we make sure that we are knowing what our team assets are? We all come from all sorts of walks of life. We've been involved in many different roles prior to coming into the healthcare setting. So what do we understand? Team talent, what's their strengths? What's their capacity? How can we really leverage off those? So this is something that you might want to do just as a team building activity. It's really nice to get them to do. You can even do it when you're doing a performance review. Finding out what they understand their role is within the organisation, not only from their PD perspective, but also from where they can see opportunities. Think about innovation. What is their data showing that people can be involved in? And then, Riff, if you want to step through to the next slide. When we have an idea and we've budgeted it out, as Riff said, we need to make sure that we can actually viably do this. And we saw this with COVID and people putting in an EOI to give the immunisations. People are having to number crunch and work out, is this going to be worthwhile? We need to put together an effective team to make sure that we start to talk through all those key elements that are in the APNA, nurse-led building blocks, and as well those thinking points that Riwka described in that mind map. So we might form a team to discuss this, and that is a purposeful discussion on what could we do. So what key players have I noticed, particularly when I'm building a nurse-led clinic? It's really important that you have obviously the top-down endorsers, such as your principal exec team. Don't forget your admin team. They're crucial. They see so much. And obviously, who else is going to be delivering the care? Obviously, the nurses who you know are going to be passionate about this project. So we form and we put in place ground rules. It's essential that everyone understands what their role and responsibilities are going to be here. And brainstorm to your heart's content. Brainstorm and think big, okay? Don't think about what we can or what we've seen. Think about what might be. How could it look? What ideas does everyone have? Because inclusivity is important here. And we might have some robust discussions. That's very normal as we move through that storming process. And Riff and I were having a discussion prior to coming onto this session that if you lose a key player or any player within that initial team, you may go back to that forming stage again, setting in place ground rules, working out what people might want to take on in terms of a role here. Again, the storming. And then we find our new pathway with the norming of testing. 1% little tweaks and adjustments here. Think of your PDSA cycles of putting in place change. Change does not happen by implementing everything at once because we want to tweak, refine, seek patient feedback and discuss whether or not it's working. Riff, do you want to move on there? So this is from a real nurse-led clinic that I helped mapped up. And as you can see, it's very much in that stick-it note, put in your texters, work out what kind of time frame are we talking about over a year, which team members, and this is called swim lane mapping. And it also does things like thinking about what item numbers you might use. So then I would navigate them to the APNA budget tool planner and say, key those things in and let's work out where the opportunities are and whether this is going to be viable. Have we thought of everything? Because there's item numbers on that budget tool planner that you might go, actually, we might be able to use that. And you'll see on that orange stick-it note when you have these slides later on in print form that they've thought about things such as prevention item numbers, such as health assessments, etc., and 10997 item numbers. You know, if you're doing an Aboriginal Torres Strait Islander, you might use it 10987. So it's just starting to put down not only the MBS item numbers, but delegating roles and responsibilities. Riff, do you want to move on there?
Yeah, and I was just sort of thinking about the old 729s, the case conferencing item numbers there as well. They're usually the poor cousin as well, aren't they?
You betcha. And there's nothing like having a 3D handover. What I want you to really be mindful of is checking your team on a frequent basis. We have no doubt been through a lot of change of late. There has been one lockdown after another lockdown, and dare I say it, we're in another now. So really being mindful of people who you might think, why aren't they taking and seizing this opportunity of this new nurse-led clinic that we're developing? Or why haven't they done those steps that they said that they want to be involved in? Really start to check in for change fatigue within your organisation and make sure that you're addressing that. Because it may not be that they're being change resistive or being putting up barriers per se. They may be expressing exhaustion. So that's one thing to really make sure that you're mindful of, because the last thing we want to do is invest a lot of time, energy and effort in, you know, developing up these clinics, investing in CPD time, and then people burning out at a rate of knots. So also checking in on that as well. Riffy, moving on. So there's a few key things, isn't there, that we need to do and to make sure that this hums along beautifully. Number one, top of the charts, is effective communication. There's no doubt about it. How are you going to communicate with this group that you've formed to implement a nurse-led clinic? You've gone through the ideas, you've gone through the brainstorm, you've mapped it out. Now what? Are you going to use platforms such as, I don't know, WhatsApp, for instance, or what's a couple of others we use? Riff, Slack is another one.
Yes, absolutely. Slack is a favourite, isn't it?
It is a favourite. Or are you going to have huddles? Are you going to meet and physically talk about this at a regular interval with that team? And making sure that you're engaging diverse skills. You want to make sure that you're getting lots of different perspectives. If you can, Put together like a little think tank, even with your patients, on what they see it look like and how could it be really useful for them. Make sure that we're really starting to understand what our roles are in this as well. We've always got to have that lens of what are we trying to achieve in terms of outcomes here? What is our measure? So get back to that PDSA again. And we want to make sure everyone's really clear on why we're doing this thing. Otherwise, everyone goes, oh, why am I having to do this? I'm already snowed under. Why am I having to put time, energy, and effort to it? If I know this is going to be really great for my patients, but I also know it's going to be great for me as a team member, I'm going to be a lot more enthused. So clear communication of inclusivity and making sure that I have the right team members and the skill mix to assist me to get there. And guess what? Just when we think we know what we're doing, the whole world tips upside down again. So we need to be really flexible, don't we? And we need to understand that this set in stone is not going to be the way that we're putting plans in place from here on in. We can have an idea, we can have an intent, we can have a direction, but as legislation changes, as a pandemic changes, we're going to have to adapt to that. So 1% is a bliss spot because we can adapt really quickly. Moving on, Riff. We need to have a leader. And that doesn't need to be the manager. It's someone who's a great communicator, who's very passionate about this particular project and who can bring team members along the journey with them. And we need to make sure we're watching for this very thing. And this is the one that's quite exhausting of late, I know. And that is camaraderie, team culture. When things are challenging and we're all stressed and there's a lot going on, this is the one thing to stop really quickly. So how can we make sure we keep cultivating that, making sure we affirm what we've acknowledged in our workforce during the day, the good work that's been done, yeah, not with praise, but actually objective language of acknowledging their strengths and the things that they've done and implemented that's helped everyone and been assistive for the day. Just making sure that we're showing up, that we're in it together. Yeah, it's hard work at this point in time. Is there teaching and training opportunities, just like what you're doing today? Fabulous opportunity to get some free CPD in, all condensed into one platform. And we want to make sure that we're acknowledging that personal attributes. And that's where I was talking about the team assets. What things do they know about themselves, or what do you know about them, particularly as a manager, that you know that that person stays calm in a crisis, or that person's really good as a communicator, or that person's really good at tuning into how everyone's feeling in this space. And we want to make sure that we're always on the lookout for what opportunities are in there. So looking at your data and keeping your eye on what MBS item numbers are out and about. And this is where your PHN will be no doubt a rich resource for you. And Riwka's page on Facebook is just across this, no doubt. You know, we have temporary COVID item numbers and they're changing all the time. There's a lot of information there to try and take on. And if you can take it into palatable bite-sized pieces where people are making it really simplistic and easy for you to absorb, that's where I want you to just keep your eyes on the prize there, just to see what's available to you and how can you use that to your best advantage. And that's pretty much me in a nutshell, Riff. I just think that if we can really start to even share models of care so that someone else sees it and goes, wow, actually, you're just like my kind of clinic, and I see that often in your page. Maybe we can adopt it. And, you know, in the APNA page, there's nurse-led clinics there that you can follow along as case studies with all the budgeting and the planning, etc. It's getting the team right, though, isn't it? That's the bliss point.
Yeah, look, this is exactly right. So the slideshow has kind of finished. So keen to have a chat with the panel too. Linda, can I check in with you to see if there is any questions that have come through from the audience for us to discuss?
There's one, or Mark Dempsey's put the link up to the billing and funding tool on the APNA website. So thank you, Mark, for that, because I was going to do that. And Tracy Murphy is a little bit off topic, but it did come up a little bit yesterday.
We don't mind one bit.
Exactly. Let's go. The healthcare homes trial is ending soon, and the results will inform the primary healthcare 10-year plan. But does anyone know what is happening with the 10-year plan, and if there is anything in this plan that will support a stronger role for nurses in primary care? And I think we heard Alison McMillan this morning talking about the nursing strategy towards 2030, and the elements that she talked about in regards to nurse leadership, building capacity, the role of the nurse practitioner. But and there were others, I didn't get them all down. But any thoughts from you around healthcare home trials and what they're contributing to nursing going forward?
Well, look, my understanding is, and I don't think anyone can say definitively at this stage what's going to happen, because, of course, these things always roll out at the last minute. I certainly don't have definitive answers. What I have understood is that the trials of the healthcare homes are going to be wrapping up, and that by and large the pathway forward is not going to quite follow the modelling of what the trials have put out there. But I do get the sense that there is good understanding that team-based care, that's not going to go away. That has to be developed further, because that's really where the future lies. I mean, we don't have enough GPs to do all this work. We really do have to focus on the right person, the right skill set for the right task. And so I don't think that's going to go away. But in terms of what that's going to look like, ultimately, I don't think anyone knows. In the short term, what I have heard is that it is going to be likely that there's going to be a shift in the way that especially care planning and chronic disease management is going to be funded, to put more emphasis on the ongoing support of the patient and less so on the initial care plan. So that's kind of going to get away from the episodic care planning and then not focusing so much on the reviews. And, that's really undesirable. So I think there's going to be some Medicare changes coming through in that space. But as to when that's going to happen, I honestly couldn't tell you. Kim, have you got any further thoughts?
Of course. So we start to see snippets of it coming through and talked about, don't we? So we heard about voluntary enrollment that was going to start, and then, of course, had the time out. Thank goodness they didn't bring that in amongst everything else. But voluntary enrollment's absolutely coming from the healthcare home trial, isn't it, of making sure those chronic disease patients are signing up to your team to have all their chronic disease. And that's going to be a beautiful thing. I mean, to make sure that you're not having to chase, did someone get care down the road? Again, that proactive prevention screening and assessment from their regular team provider, crucial, absolutely crucial. And when we look at the MBS task force review as well, they're highlighting things such as, incentivising reviews for patient outcomes. And so a couple of particular areas where Riff may mention before, where we have workforce shortages, we're embedding strong nurse-led clinics. And it's essential. We've even got one rural area where we're using telehealth nurse practitioner after our models. So there's loads and loads of new ways of working through, which is super exciting, and people understanding the strengths of what nurses can bring to the table. And again, just allowing for there being a business model associated with it, appropriate skills, appropriate endorsement of what they can do. And I think this is where I'm starting to see a lot of change in this space, because, we're even seeing medical assistants coming to support nurses. Now, nurses have been in demand like never before, of course, because we've got the COVAX rollout. And so we're seeing a lot of nurses being drawn into this space as well. So it'll be interesting to see how, nurses are utilised moving forward in terms of immunisations, chronic disease management and prevention. Obviously, it's a passion project of mine to spend a lot of space in developing nurses in this skilled area, because there's a lot of prevention opportunity here, isn't there? And there's also a great use of skill set. It's more viable for nurses to be in this space.
Definitely. And I think, it talks to the work that Appen is doing around profiling the range of nurse clinics out there, but it also talks to the point of the importance of evaluation and whether and just awareness. So whether that's just is it Coast PHN, Kim, and they have the portal, and they have lots of the quality improvement activities of the practices, and really profile what the clinics are. I think there's definitely an opportunity to highlight how nurses are contributing in this space. Yeah.
So this is one of the areas that I do a lot of work in, and it's called the Primary Care Impacts page in Healthy North Coast. And whenever we have a particular case study that we think could be replicable and scalable, we absolutely pop it on there just as a little kind of case study that you can follow along. And that's open source. So if you think, wonder what we could do, absolutely go and have a look there. And of course, APNA as well, because, you know, if you can have already some information to start you off and then you adapt and tweak and adjust it, that's a great place to start, because you know obviously that model's out there working somewhere.
Yeah, this is it. You really don't want to be reinventing the wheel, do you? You know, whereas we speak a lot around sort of innovation and what's appropriate to your practice. In many senses, there is nothing new under the sun, in that if you have an idea, chances are it's already been trialled, and all of the testing and all of the falling over and all of the good bits and the bad bits have already been experienced. If practices can learn from that and take that on board, it might save you a whole lot of time and a bit of heartache as well. So yeah, still shamelessly, you know, someone somewhere said.
I think that's the great Tony Lemke.
That might be right.
Heard Wally Jamal talk about, you know, this failing forward analogy as well with the healthcare home trial. And he said that initially they were going to implement a new service delivery into their organisation, and they thought they had told everyone and informed everyone. And so they went about and they thought, yep, we're going to start small. They had the methodology right, but one thing they didn't have in place, and that was effective communication. What they forgot to do was tell the very person that was going to be answering the phone on Monday when all these patients were going to ring, that this new service delivery was happening in their organisation. So really important that we might have all the thinking and the planning and the budgeting, but don't forget the key thing, effective communication to all team members is super important, because there's nothing worse than that external image of your organisation coming undone because this person at the front desk has no idea about what it is that you guys are delivering and how you're going about it, and even which team members are actually involved in this project.
Yeah, it's a big piece of work, isn't it? You know, keeping everyone aligned. It just requires that ongoing enthusiasm and I guess resilience too. And I'm mindful that at this point in time, especially in Victoria, where, you know, here we go again, you know, resilience is kind of taking a little bit of a hammering, and you'd really want to just sort of factor in your timing of introducing new services as well. And I know that there will be many practices at this point in time saying, we have so much on our plates, especially around the COVID vaccination rollout, that this may be something that might just need to be put on ice for a little bit, because the timing is just not right. Because the last thing you want to do too is just to hammer your team and then have them kind of going, I can't take any more, this is just too much. So just being really realistic about what you can achieve, but let those ideas kind of bubble on in the background of, you know, what's going to come next, you know, where are we going to find that innovation once we're in a different space again.
So, Riffy, like on that note, like there are things coming out, isn't there, such as the RACF COVID item numbers, the temporary ones, for instance. So again, just being mindful of, okay, well, will we or won't we be involved in that? Will we have a discussion about what does it look like, and can we do it? Do we have workforce? Do we have enthusiasm? Is it viable? All of those critical things, those discussion points are the same, aren't they, really, no matter whether it's an innovative service delivery or whether it's being responsive to what's come out as a strategy to bolster this industry while we've got COVID-19 coming. So the same processes are applicable no matter whether it's completely new or you're seeing changes with regards to the COVID-19 item numbers.
Yeah, I think that's all the same. Linda?
Oh, yeah, that was me. Got a question for you.
No.
So it's in regards to funding. So Sonia's asking, these changes really need to be linked to nurse time in most practices. The nurses do 90% of the work involved with the 721, 723, etc. already. So just talk us through, Riwka, how you might model that in the budget template.
Yeah, so you'd be looking at that both from the revenue point of view as well as the expenditure, of course. So the budgeting tool allows you to predict how much time your nurses are going to spend on certain activities, whether it's care plans or team care arrangements or health assessments or whatever it might be. And different practices will have different metrics for that, which is why the tool is designed to be really flexible to take into account, what actually works for you, rather than saying it should be this or it should be that. So look, you're quite right, Linda, too, that part of the problem with developing the business case for nurse-led clinics is that there is often a bit of a disjoint between what GP revenue is going to look like out of that versus how much input the nurses have to that to that scenario. So I guess I would be challenging practices to look at the timing involved and then map that out. And I guess I would say that it's probably not likely to be feasible for GPs to be earning their normal fee split out of these very specific nurse-led clinic types of scenarios, because there is simply not enough money left over to pay the nurses for the time of their involvement in this. As much as I would like to see that differently, I wish it wasn't so. The practicalities of the way that MBS funding happens at the moment really does indicate that a normal fee split is likely to make it a very marginal scenario, or perhaps just not viable. So I guess I'd be encouraging practices to think closely around especially the funding that they get through QIPIP as being part of the revenue that they are factoring into this, as well as the workforce incentive payment for nurses. But then also really just have a look at what is a fair and reasonable split with the GPs in order to keep this viable. And I guess the tool is really good too in that you can put different scenarios forward. And when you can kind of see very clearly on paper what the outcome is going to be, it makes it much easier to have the conversation with the team around how could this service work, or what do we need to do to make it viable. So as an example, the way that I have run this within practices that I have worked with is to really give the GPs the option. So, for most practices where GPs are working as independent providers, they are essentially in control of how that plays out. And it's not as simple as saying, well, you're going to get a lower percentage for this. It's just not as simple as that. But by being able to kind of just, put it on the table to say, look, this is what it's going to look like. On the one hand, for a normal fee split, really the GP needs to take responsibility for the entire work of the care plan, or health assessment, whatever item number is being applied. Or if you see value in what the nurses are providing, then it just needs to look differently. So I guess there is a challenge also there for nurses. And I think we need to get away from nurses as being information collectors, which is in many cases still what happens in these sort of nurse-led clinics for care planning, and make them an integral part of delivery of health services that are valuable to the patient. And I know, Kim will be nodding along these lines, because this is really your space along it as well. And I guess where I have challenged the either or scenario in terms of the funding of, either the GP does all of this themselves or they incorporate the nurses, that the value of the nurses needs to be tangible and visible and well expressed. Because then what happens is that not only are nurses working to much better scope of practice, they get better, satisfaction from the work that they're doing. Patients are getting a better outcome because, hey, guess what? They actually really like what nurses are able to offer. But in that space, GPs are able to not only, of course, still earn from the activity that's being undertaken, but they can also be attending other patients at the same time. So it's the entirety of that conversation that brings the richness to the decision making of, which way are we going to go. Kim, have you got further thoughts around that?
Look, there's loads of different business models associated with this, isn't there? Like there's loads of different pace, as you said, in terms of splits of the MBS. Nurses, some have been getting actually remunerated for care plans as well. There's lots of different ways of going about it. It's again coming back to what's going to be viable for you. I think that if we're talking about value for the patients, the dollars are going to come. If we think about patients are perceiving that they're getting really great quality care and they're engaged in care planning activities and really enjoy that proactive discussion, goal setting, going through screening and assessments with their nurses, red flags handed over to GPs, many eyes on a patient and bolstering lots of support around a person to keep them well supported is just a no-brainer for me. And I think the more that we can keep that as our central focus of what we're trying to do, the money's going to come. It's going to be there.
Yeah, I so agree with that too. And I do have also direct experience with the fact that, many practices presume that because we are so often constrained by the MBS, that there is no capacity for patients to contribute to the services that they receive. And that is not always so. I mean, there may be situations where that isn't feasible, but there will be many examples where that's quite sort of a false presumption. So I've certainly been directly involved in developing nurse-led services where there isn't an automatic service associated with a GP for that, and that the service is completely privately funded. So patients are booking into a nurse service and they are simply paying for that service. And, in the beginning, that was a bit of a trial and see how that works. Will there be demand for the service? And this kind of comes back to that notion of, what is the skill and capability of the nurses to actually drive such a service? But, the example that I'm thinking of is a cervical screening clinic, which was entirely nurse-led. And there wouldn't be a GP involved in that unless that was clinically indicated. And, that was a private fee, and we were certainly not looking to make that a huge money spinner, but it was delivered at a time that was really practical for patients. So the nurse clinic was actually held during the week on the evenings because we would be looking to target, working women and wanting to really develop that more from just a cervical screening service into something far more holistic. So it's a far more wide-ranging conversation around mental health and support and family situations and holistic healthcare. And, the word of mouth that was generated through that service was just remarkable. And as much as we had really high enthusiasm coming into it, we were gobsmacked by the feedback that we got, that it was actually so well received. And, it even took us by surprise. So it definitely can be done.
Thank you, Riwka. And I think, again, that sort of example shows the value. That's the value proposition that you want to highlight in nurse clinic models. Just a question from Anonymous, or maybe a comment. So how can nurses become involved in changing MBS funding? Most doctors just interested in the dollars, and I have to disagree with that. I've worked in this space for a long time and quite a few years, and I think we're talking about financial viability of a business. So yes, they are interested in the dollars, but that's around keeping the business running. But Alison McMillan talked about, in regards to the nurse strategy this morning, that they are looking at funding models. She did acknowledge that MBS doesn't really support nursing in general practice, and it was really good to hear that. And there are peak bodies that contribute to government around talking about nursing and MBS. And I think we saw that last year when the telehealth items came in early. The 10997 initially wasn't included, and that changed. Is that correct? Am I remembering that right, Riwka? For telehealth?
Yes, I think that's correct. Sorry,
And
I'm
also,
going back into a thinking space now that I haven't been to for.
and also care planning. So care planning wasn't initially involved. It changed on a weekly basis, right? That's why Rick's going, what? So yes, it did. And initially everyone was going, well, we can't do chronic disease management. And then the chronic disease management was item numbers, COVID temporary item numbers were responsive to that cry out for, hang on a second, we need to still be able to do these things. And again, I would like to chime in there as well and say that the evaluation components of nurse-led clinics are super important to inform MBS as well. And the MBS task force review, if you go and have a look at that paper, looked at how many times a particular item number was billed over a period of time, what it was used for, what its bang for its buck was. So again, the more that you're utilising these things and demonstrating good worth and outcomes for patients, because that's essentially what we're after here, then that is reviewed, not necessarily by someone like me, but by people who have been employed from the federal government to go and do it. And that's, you know, again, evaluations from primary health networks, senior nurse-led clinics, the governing bodies such as APNA, etc. They're key ways of getting Medicare change through advocacy.
Yeah, absolutely. Just a quick clarification. It was Healthy North Coast, PHN, is
that right?
Yeah.
So Healthy North Coast Primary Care Impacts page, it's open access. You can see lots of my work up there. There's loads and loads of little video vignettes. But more importantly, you'll see a lot of my nurse-led clinics up there demonstrating through being interviewed, little case studies on what they've done, and also their PDSAs on how they went about that.
Yeah, and Westvic PHN, just to spruik us, we're also working on our own portal. And again, if you've got a nurse clinic project that you're working on and you want us to highlight that, then let your practice facilitator know as well. So yeah, we're working on getting our portal up and running as well. Anything else? Riwka, I've lost Kim.
It looks like Kim's fallen off the portal for a bit, but look, I think we're close to wrapping up the session. Have any other questions come through, Linda? There she is.
I think no, there's no more questions. We've tackled them all. I think the topic of funding is always so it's such a challenge in general practice for nursing, but there's lots of resources out there and lots of experience. So I would encourage people to follow up with what you've heard today. But any final words from Kim and Riwka, given that we've got 2.5 minutes, and leave me with a minute?
Yeah, I think that if you have we being the key word, we can adapt, we can be responsive. We just need to make sure whether we want to. That's probably my main takeaway. Look after your humans. This is not a sprint. It's a long haul, right? So check in with each other regularly. Yeah.
And Riwka?
Yeah, look, I don't know that I can trump that, but I would probably echo that. Maintain enthusiasm, maintain energy to undertake this work, and I guess in order to kind of feel ready to tackle that, we really need to focus on individual capacity to recover from the stresses that we are currently under. So plenty of self-care and downtime too, so that you can come back to work with some of that freshness and enthusiasm to tackle this stuff, because it is complex. It is it does take thinking time. It does take active planning. But I suppose the other thing that I just wanted to touch on too is just the overlap with the thinking and the methodologies around this, together with the QI PIP program as well, that when you're doing this well, it kind of ticks off into so many of these compliance programs that I know you're all working on, and that includes RECGP accreditation as well, that when you develop these services, this is all about quality improvement and better patient health outcomes. So that's probably my final message.
Fantastic. Thank you very much. So thanks, Kim and Riwka. It's always a pleasure to be in a discussion with you, and it certainly looks from the feedback that everybody looks like they've really enjoyed it and very valuable. Okay, so before everybody leaves this session, there's an in-session evaluation for you to complete. So do that before you exit. And we've got a 20-minute break now before our next session, which begins at 12:10. So take some time to stretch your legs. Go and have a look in the sponsors lounge and go and have a look at the Westvic PHN resources as well. And you keep earning points to go in the draw for the $200 book voucher. So yeah, get ready to come back. You've got 20 minutes, and look forward to seeing you again at 12:10, where we'll be talking about employment issues. Thank you very much.